It's past 6, so I'm going to start. My name is Dr. Talha. I am currently working as a trust grade doctor in trauma and orthopedics in Nottingham University Hospital, Queen's Medical Campus. So the purpose of arranging this course is we have organized this course as an MRCS Part A preparation. It's going to run for the next around 10 to 14 weeks, depending upon the speakers. So the course is going to touch topics related to MRCS Part A. We are grateful for our esteemed speakers who are going to join us for the next few weeks. We have got, luckily, we have got specialist registrars and consultants from various specialties to give us an insight what is going to happen in MRCS Part A. And so just a brief 1 minute introduction of MRCS Pathway is that because MRCS Pathway is required for if you want to apply as an ST3, and it is also it gives you marks if you want to apply as a core surgical trainee. It has two papers, a Part A and Part B. So Part A includes the basic sciences, and Part B include the principles of surgery. So Part A will have 3 hours and 180 MCQs, and Part B will have 120 MCQs and 2 hours, and you will get 5 hours to pass pass the exam. And basically, it's the passing criteria is around 70%. It may increase or decrease, well, depending upon the paper. Well, it's around 70%. So I've got Madam Tabinda, who is the consultant endocrinologist, and she is our chairperson of KEMCA UK. She's working as a Royal Cornwall Hospital these days. And then I've got Mr. Syed Turab Shah Saab. He is a trauma and ortho consultant in Scotland. He's working as a consultant in Forth Valley Royal Hospitals. He has been working in England for quite a time. He has been involved in various hospitals, and I'm very thankful for both of them to join us today. So I have got Dr. Amir. So I'm going to go to Dr. Tabinda, if she can have a chat and do something about it.
Thank you, Talha, and I'm really honored on behalf of KEMCA UK. I can thank Talha and I can thank all the participants because we take pride in carrying on our tradition of teaching and spreading all the knowledge that we the others and sharing it. So I'm sure this course will be a useful addition to what we have been doing all along in the last few years, webinars, etc. And Talha has has put in a lot of effort in this course to organize all the speakers. I'm pretty sure everybody will find it very useful and helpful in the preparation of MRCS. And as well as that, I have got a very esteemed an exec with KEMCA UK, Dr. Turab Syed, who is an orthopedic surgeon, and he has very kindly offered to monitor and quality assure this course. So I'll be very brief. I'm only a physician, so I don't know how the surgeons work. I'm married to one, but I don't still know how he works, so I don't know how the surgeons work. So I'll pass on to Turab, and I will just disappear off the screen. I'll be listening in though.
Over to you, sir.
Hi. First of all, thank you, Talha, for organizing this, and welcome to you all. I have taken a back seat and I am not teaching you guys because I did my MRCS almost 2 decades ago. So my knowledge is rusty. I've become more
So
I would leave you guys with Talha, and please do give us feedback because that would help us to improve it. And be honest, you don't have to say we're doing good. What we want to know is that we're not doing good, so we can improve ourselves. And all over to you.
So I've got Dr. Amir Khawaja. He's an ST5 in Nottingham University Hospital. He's working as a specialist registrar in general surgery, and I am really thankful for him to join us today and to give this lecture. And secondly, I would also like to thank KEMCA UK and all our esteemed members to give us this opportunity to start and kick off this series. And we really hope this series is going to help a lot of guys who have started preparing for the MRCS. And we're aiming for the people who are going to aim and give MRCS Part A September attempt. And hopefully we will like your feedback on this, and I'll make sure that you get a Google form at the end of the day. And we are it's going to be 10 to 14 weeks of sessions, and we'll be live every Thursday, 6 p.m.
I'm Amir Khawaja. I'm one of the ST5, the surgical trainee at Nottingham, East Midlands Deanery. Thank you first for Talha for having the initiative of starting this thing, and obviously KEMCA to give him the platform to do this preparation for MRCS for different sessions relating to the surgical specialties. So what I've been told is to talk about one topic, which is acute abdomen. As I said, I'll try my level best. It's going to be 30 to 40 minute session, but it's not exactly teaching you anatomy or teaching you surgery. There might be many people in the audience which might be very much competent in doing surgeries and all those things, because you're preparing for MRCS, irrespective of whatever your competencies are. It's all about what exactly is expected in this Royal College of Surgeons membership exam. Rather than just knowledge, it's more about how to tackle with the MCQs and how to go on with those. So that is what I'll try my level best to give a bit of an idea about what this exam specifically relating to the acute abdomen, the questions and the various topics in acute abdomen are. I'll just try and get this presentation now. Yeah, right. So let me just get the full screen. Yeah. Right. Okay. So first thing first. So as I said, can you hear me? Oh, sorry. Yeah. So as I said, it's a good thing that we've started these Zoom sessions. I mean, generally in the world for the last 2 years, one of the very few positive things probably from the COVID times. Firstly, it is a good thing that you don't have to go physically anywhere to attend the courses. Secondly, yes, you can, you've got a small time, but you've got many sessions, which is encompassed in a small time, and you can actually revise those sessions on a weekly basis before you prepare for exam in September. And thirdly, for us, for speakers and all those things, it's always better to stay at home and give these sessions. And one last thing for Zoom sessions, that you don't have to even iron your pants nowadays, isn't it? Anyhow, getting back to what MRCS is. So Talha has given a bit of an explanation. So MRCS Part A, 2 exams, Part A and Part B. I'll talk about Part A specifically. You've got 300 questions. You've got 5 hours, a single best answer MCQs, with the paper 1 in the morning and paper 2 in the afternoon. The paper 1 is primarily applied basic science, which is a 3-hour exam, written exam. It's got 180 questions, so it's exactly 1 minute per question. Just a second, I'll just for a second. Can you keep this thing away from the screen? And the paper 2 is basically principles of basic surgery, and that is a 2-hour exam, written exam. Again, the single best answer MCQs, 120 questions. The pass mark has already been explained, 70-75%. It varies, but you have to give your best. You have to make sure that when you come out of the exam, you actually try to attempt each and every question. There's no negative marking, straight hold. You have to attempt each and every question, make sure you do that. The million-dollar question: what is the time for the preparation of MRCS exam? Well, it varies. It depends. You're working, which hospital, what specialty you are in. Normally, they say 3 to 4 months. If you're giving 2 to 3 hours every day is a good sufficient time. It varies. We know we're not school-going kids. We know this varies from person to person. But generally, if you give a good 3 to 4 months time period, it is normally considered sufficient. Sorry. This is exactly the reason you need to do MRCS. I mean, obviously you can get GMC registration. You need to get an ST3 training. This is generally I won't spend much of a time on this thing because my topic is acute abdomen, but just a bit of an introduction to this thing. So this is actually a surgical specialty training in UK. Starting from foundation 1 to 2 comes after the medical student. And then you get an interview, get into CT1, CT2. Now, this could either be a core training of 2 years and 6 years of training, specialty training, or you can have 8 years of specialty training starting from ST1, something called as a run through. However, the criteria is that before getting into ST3 specialty training, you need to pass the MRCS exam. Obviously in ENT, it's a bit of a different dance, but generally this is the criteria for MRCS exam. So my topic today is acute abdomen. What is acute abdomen? You all know that. It refers to severe sharp abdominal pain or any symptoms related to the bowels or the surrounding tissue. It could be retroperitoneal, any mesenchymal tissue, and the abdomen. It is, yes, amongst the top 3 to 4 conditions which presents in the ED. And that's why it requires very urgent diagnosis, some sort of a plan, and immediate management. This can be life-threatening. Not only that, increase in morbidity and mortality. And that's why we have to be very careful in giving immediate management to an acute abdomen patient. Now, as a sort of an abdominal area to talk about, this is normally considered as the Bible of the abdominal pain by area. So I'll go with these 9 areas. What exactly is the expectation from you in an MRCS exam? Everything today explained is not, as I said, is not giving knowledge about abdominal pain. It's more about how the questions are there. So you talk about epigastric pain, and yes, we know we go from skin back to the skin, from skin to skin. We talk about peptic ulcer, we talk about gastric cancer, we talk about esophagitis, gastric ulcer, and yes, gallstones. 40% of the patients with gallstones present with epigastric pain, not necessarily right upper quadrant pain. And then you go to the right upper quadrant area, you've got a liver, you've got a gallbladder, you've got a biliary apparatus. So all those things, either it's the structure itself, which is a liver causing liver abscess, or it's a liver cyst, can cause a pain, or it could be the gallstones called as cholelithiasis, or it could be the inflammation of the gallbladder called as the itis of the gallbladder, which is cholecystitis. Again, it could be the CBD stones, the common baldric stones, or it could be the itis of the common, which is the cholangitis. And last but not the least, obviously, hepatitis, which is not, I'm going to touch more at the minute. Left side, left upper quadrant, we've got a spleen, things relating to spleen, even to the tail of the pancreas, if you've got pancreatitis, splenic abscess, splenic rupture, and splenic infarct. Even you can have a colitis of the left, which is a splenic flexure. You can have a diverticulitis, diverticular going all the way. So whenever you're getting questions relating to pain in these areas, these things should be in your mind before you attempt a question, so that you rule out 1, 2, 3, 4, and they'll give you a clear-cut clue in most of the questions, which will actually indicate the diagnosis. Coming down into the lower abdomen, in the middle side, we're talking about both lumbar areas. Renal colic pyelonephritis, very typical, and in the middle is early appendicitis, Meckel's diverticulitis, or small bowel obstruction, or even at times large bowel obstruction. Lower abdomen is more about, typically the more questions come on that area. It's right upper quadrant, right iliac fossa, and the left iliac fossa, which encompasses most of the questions pertaining and relating to the abdominal area, which includes diverticulitis, cecal diverticulitis, or sigmoid diverticulitis, colitis, or inflammatory bowel disease. It can be in females as ovarian cyst, ectopic pregnancy, urinary tract infection, testicular torsion with a referred pain, and obviously, last but not the least, in fact, the most important is appendicitis. We will discuss them in a bit of a detail, but in the sense to give a bit of an idea for all these things. Hernias are, yes, very important. So please, please, please cram up the hernias. I don't know, there's one way or the other, but you just have to remember the diagonal hernia, indiagonal hernia, what comes lateral to what comes medial to what. That is the typical things which you have to cram around. Femoral, obviously, we go in the femoral canal. We discuss it in a bit of detail. Obturator foramen, a typical question comes with obturator with patients complaining of pain in the hip area and sometimes a small bowel obstruction. And you think, what is the ringer? And it's normally indicating obturator hernia. Abdominal side, we're talking about umbilical hernias, whether they're incarcerated or whether they're strangulated. The question would be very typical. If they're irreducible, they are painful, and the patient's complaining of vomiting, signs of blockage, then they're obviously strangulated. Don't just go for incarcerated, strangulated hernia. Other than that, the weird names, Spigulin hernia, it's a hernia, as you can see in the diagram, which is at the arcuate line and where the semilunaris meet at exactly lateral, that we get the Spigulin hernia. Lumbar hernias, obviously, you can have incisions or you can have some defects in the muscle in the lumbar area causing these hernias. And then the 3, 4 specific ones where they always ask one of them. It could be the Litter's hernia, which is a hernia containing the Meckel's diverticulum. Again, there's no way of learning, it's just cramming of the terms. Richter's hernia, it's the sliding hernia, which is a part of the bowel herniating through, compromising the bowel lumen and obviously leading to either obstructive symptoms. Ammian's hernia, in which there's an appendix in the inguinal hernia, and the middle, which is the 2 lobes of small bowel forming actually a reverse sort of a W-shaped thing, forming the hernia. Some of the hernias, as I said, Bugdadal hernia, which is a diaphragmatic hernia, big defect in the left side. It can be a congenital defect and can happen 90% times, it's mostly congenital. And the Morgagony, which is to the foramen of Morgagony. As I said, come up these hernias. So if you give any indication according to the region, so they might come up with a question in inguinal hernia and femoral hernia together, and you will have to differentiate between these two. We'll discuss that in a minute. Inguinal hernia, as I said, typical terms: pubic tubercle, supromedial is inguinal hernia, and we talk about femoral. It's infralateral. Now, when you remember these things, it's always tough. You can say, oh, it could be infralateral, why supra? The simple answer is inguinal hernias are normally above the inguinal ligament, and the femoral comes beneath that. So one thing is for sure, you should remember anatomy-wise, it is going to be superior. And while lateral, Well, the way I usually do it is because inguinal hernias are more common, so we stay in the midline. And the femoral hernias are not very common because there's more lateral in the body. So that makes medial and infralateral. But it's basically the anatomical picture which describes the position of the hernia. Gender distribution. So a journal question, we will try to make it a bit more interactive, and you can obviously raise your hands at any point if you've got a question at the end or even in between. I don't mind at all. So what is the most common hernia in males? And we know that's inguinal hernia. Now, what is the most common hernia in females? Now, this is where exactly the mistake happens most of the times, because we've been reading the females get more femoral hernias than males, but that does not mean that they're still not that common. So in males, out of 10, 8 would have inguinal, 2 would have femoral. But in females, 7 would have inguinal, 3 would have femoral. So it means femoral is more common in females. But if a question comes, what is the most common hernia in females? I'm afraid it's still inguinal hernia. So this is one of those questions that comes down more or less. Then obviously cram up the walls. You need to have a look at the Netter atlas, but basically you have to cram up this groin area, the inguinal canal, roof, anterior wall, floor, the posterior wall. The roof, we know, comes up with these conjoint tendon things. So you have to make sure the internal oblique, transverse abdominis goes down and dips into the medial wall. And then the anterior wall is made up of the aponeurosis, the external and internal oblique muscles. And the aponeurosis, basically. The floor is made up by the inguinal ligament, lateral, and medial, it's a lacrimal ligament. And the posterior wall is a transversalis fascia. This is at least one question, there's no doubt about it, about the inguinal hernia. What other things they can ask about is whether it's a direct or indirect inguinal hernia according to the position. And they might ask exactly about a condition. They might say a 76-year-old man coming in with abdominal pain. They might not even mention the swelling, and they might mention 76-year-old man coming with virgin abdomen, maybe. And they're saying that it has been vomiting. And then at the very end, they might mention they've got a small swelling in the right. Normally in MRCS, it is a hernia which is causing the obstruction. Don't try to overthink over the questions at times. Femoral hernia, we discuss again the femoral canal, the femoral ring, these boundaries. So you should know the femoral canal is there by Mother Nature because of the, if the femoral vein is there, it needs something for the dilatation. So it gets a bit more lateral to that. So the position which we've been cramming since first year in the medical school is that the vein artery nerve, it goes from medial to lateral. Same. You've got a femoral canal, as you can see in the picture, the yellow one. The blue is a bit more lateral, is a vein, and a bit more lateral would be the artery. On the medial side of the femoral vein is a femoral canal. That's where exactly, the medial side of the femoral canal is the lacrimal ligament, behind the pectinis, and the front is the inguinal ligament. Again, these boundaries are important to be learned, and you get a question out of them, because a typical question is what is on the medial or the lateral side. One of the most important questions, which comes around in different ways, sometimes you might actually think they're asking the same question, it's not. It's a right iliac fossa pain. Most common presentation, we notice that in ED also, in young and old patients. So this is all the differentials you should just have in your mind. When you're asking a question, right iliac fossa pain, you should have all the things from top to the skin to the back of the skin, which includes, it can be, there are not many things probably in this presentation too, but it can start with appendicitis, the most common one, ovarian pathology in females, UTI, renal colic pyelonephritis, ectopic pregnancy, mesenteric adenitis, quite common in children, viral gastroenteritis, ileitis, inflammatory bowel disease, a cecal tumor, cecal diverticulitis, endometriosis and PID, very important in females. And that's why we have to see how would we rule them out. We'll go from question to question and list presentations of the diagnosis rather than the other one. It says you're muted.
You're not muted now.
Okay, fine, sorry. Next topic is large bowel obstruction. I'll not touch much of it because it will be probably covered by most of the colorectal presentation. But what exactly is expected in large bowel obstruction is what we call about a large bowel obstruction. What are the causes? We know the tumor, wall, villus, adhesion strictures. But the picture comes like an old man who had previous lap chole, or had a previous abdominal surgery, coming in with abdominal pain, typical cardinal signs of blockage, which is vomiting, abdominal distension, absolute constipation, and obviously abdominal pain. So got one of 2 or 3 symptoms, and the patient just said, what are the possible causes? It would either be a tumor adhesions, which is more common. At MRCS level, they don't ask you what is more common, but yes, if they do ask adhesions, yes, one of the most common things. But in large bowel obstruction, it's not normally adhesions, it's normally the tumor, which is the causes. So they might give either a picture or a volvulus picture with some abdominal X-ray with kidney being shared with a cecal or sigmoid volvulus. That is the typical questions. Investigation for any large bowel obstruction. Gone are the days. Abdominal X-ray is not an investigation. In our hospital, we don't do abdominal X-rays. The investigation of choice for any obstruction picture in the abdomen is a CT scan with IV contrast. That's it. There might be an option oral contrast. I highly doubt that, because if that's the case, that's the best option. But no, it's normally CT with IV contrast. Barium MMI, yes and no, but not exactly. We give gastrographic if there's a small bowel obstruction, but not normally nowadays. And then the small bowel obstruction, typical picture, we got an abdominal, these air fluid levels of volar conventives in there. Small bowel obstruction patient coming in with previous history of surgery, sometimes even a virgin abdomen and never had any surgeries. The reasons most commonly are the adhesions. Again, the investigation of choice is a CT scan. There's no doubt about it. And what exactly is the management then? That is depending on, they don't ask for management because that's either conservative, that we keep the patients on fluids and nil by mouth, and we give them gastrographin to see if the gastrographin can open the channels therapeutically, or maybe diagnostically can show what is the level of obstruction. Or if the patient is getting sick, which is getting septic, the lactate is going high, we obviously offer laparotomy or laparoscopy for surgery. If you just give me a second, please. Sorry for the interruption. Yeah. Can you hear me now again? Yes. Hope so. Right. Next topic, bowel ischemia. The way the bowel ischemia comes, typical 70, 80-year-old man with a history of AF, with a history of PE. So basically either have vascular patch, someone who's got any thrombus previously, either in the heart and the vessels anywhere, and he comes with severe abdominal pain, high lactate, maybe having some bleeding at times. And so a thrombotic phenomena would be leading to the embolism of the vessel in the gut, which leads to the bowel ischemia. And they'll ask what is the management is. The management, again, for initial management is IV fluids, but basically it's a laparotomy. You have to take that part of the bowel out. Urgent diagnosis is very important in that, and that's why the choice, investigation of choice is again CT with IV contrast, but it has to be with IV contrast. But it's that depending on the basis of lactate. But for MRCS time, if bowel ischemia comes, that is normally the picture would be someone having an AF, an apaxivan or something, and that is an indication the embolic phenomenon has happened causing bowel ischemia. Biliary cause, I'll just be going into the basics because most of it is going to be touched by my colleague in hepatobiliary. But basically, what comes as questions in a right upper quadrant epigastric pain? Again, right upper quadrant pain, normally 90% times, they're expecting you to answer the question pertaining to biliary apparatus, which is a cholelithiasis or cholelithiasis. Or it's again the itis of the cholelithiasis, which is the inflammation of the gallbladder, or it's the itis of the CBD area, which is the inflammation of which is a cholangitis. So investigations, first investigation for any biliary issue is the ultrasound. You don't do CT scans. Yes, at times the patient is septic, but normally it's ultrasound. And if the ultrasound is showing a good picture of gallstones with a thickened gallbladder showing cholecystitis, and it's showing no CBD stones, and it's showing no dilatation of the CBD, and the liver functions are normal. I'll repeat, patient comes with a biliary colic, and you do an ultrasound that shows gallstones. The management is laparoscopic cholecystectomy. Simple. They might say 6 feet, whatever. That's a different discussion, but it's basically laparoscopy. The MRCP comes into the picture when you've got either deranged LFTs, which means there's a blockage in the common bile duct, or there is some dilatation of the CBD on the ultrasound. And that's when you go for MRCP to see if there are any stones in the CBD. The ERCP, again, is just a sister investigation of MRCP, but obviously it's therapeutic. You go in there, you look at it, but along with that, you put up a stent or you open the channels by doing a sphincterotomy. Won't go into the details. EUS is something which is very newly used for the last 15 years now. It's ultrasound, one of the best investigations, not only to see gallstones, but basically to see pancreatic cancers, taking biopsies, but also every time you do an ERCP, prior to that, you do an EUS to see. EUS is not a therapeutic procedure. It's a diagnostic procedure. But then you can do either a biopsy after an EUS or you can do the ERCP. Treatment of any biliary cause, the ones expected at the MRCS level is basically IV antibiotics and laparoscopic cholecystectomy. Two things, antibiotics and laparoscopic cholecystectomy. Yes, if the patients are sick, they are 80-year-old, they've got an empyema picture, they're very sick to have a surgery, what could you do? You put up a drain. in the abdomen, either through the liver or outside the liver into the gallbladder and drain the pus out, which you call as a cholecystostomy. And then the procedures like ERCP, as I said, you go through the mouth, you go in the duodenum, decompress the the common bile duct, or along with that, you go out from the liver into the liver channels and do the percutaneous transhepatic cholangiogram to decompress biliary channel. But that is if they cause. Not a very common question, but has come across is that someone who had a previous biliary a gastric bypass, a Roux-en-Y procedure, is now coming with cholangitis, with deranged LFTs, and typical septic picture. In a normal day, the answer would be, what do you do? Yes, we do an ERCP, we have to decompress. But someone who has got gastric bypass or Roux-en-Y, that means there is not a common channel down going into the duodenum towards. There's some other channels, or you need to do a PTC in that. You can't go through the mouth and through the gut into the, you need quite expertise for that. You normally go for, that is when the PTC normally is done in an MRCS exam. So this is a biliary tree, just to remind the picture. We all know that this is nothing like a rocket science. We've got a pancreas there, duodenum sitting there. We've got a common bile duct and the pancreatic duct opening of an ample of Vater. This is the picture of hepatic duct, the common hepatic common bile duct. That's when the pictures come of, as I said, either you've got gallstone or cholecystitis, or you've got CVD stones or cholangitis. The normal difference between both itises and the responding tissue pathology is basically fever and raised inflammatory markers, again, at the level of MRCS. And then obviously you've got intrahepatic dilatation, which actually says it's a bit of a severe disease. Typically, right upper quadrant pain, colicky, nausea, vomiting, it's a biliary colic. It's typical biliary colic. And what's the management? Pain relief, analgesia. And you don't give antibiotics. You give that time depending on what picture is, but basically laparoscopic cholecystectomy is the answer. Next picture, you get right upper quadrant pain or even epigastric pain. I'll remind you again, 30% of the patients coming to ED come with epigastric pain have gallstones because it does present like epigastric pain. Plus fever, that's the itis, which is inflammation of the gallbladder. Management, IV antibiotics. And the management is pain relief. And then again, cholecystectomy now or interval cholecystectomy after 6 weeks. And then you got a right upper quadrant pain plus fever plus deranged LFTs. That is typically when the blockage is there. When you say from the slides, the stones have actually come out of the gallbladder into the CVD, causing this cholangitis picture. Management is antibiotics, fluids, but you need to decompress the system and then later on do lap chole. Pancreatitis, common presentation. 2 out of 3 things have to be there to make sure there's pancreatitis. This is a learning point, that either you have got a pain radiating to the back, or you got a CT finding of pancreatitis, or you got a lipase amylase level 3 to 4 times of the normal, which is variable actually in many trusts in UK and even Pakistan. But 2 out of these 3 things, if there, we said this is pancreatitis. Normally, for MRCS level, the presentation they give pancreatitis is a typical patient radiating to the back. The patient has got pain, lipase is high, and they say, what are the main causes? The causes are gallstones and alcohol, simply. Gallstones is more than alcohol. Many of the causes, as you know, snake venom and steroids and all those things, but we'll stick to that. Management is pain, and pain relief with fluids. And yes, the investigation for pancreatitis, for a stable, uncomplicated pancreatitis, is ultrasound. You don't need to see what from a CT scan to confirm a pancreatitis. You basically have to confirm the cause of pancreatitis, which is a gallstone. And that's why the investigation initially is ultrasound. However, your patient comes at nighttime, and this is a practical point, not typically massive. The patient comes at nighttime quite sick, and you're not sure that this is pancreatitis, and some alternative diagnosis can be there. It can be perforation also. Then you do for CT scan. Then obviously the complications are necrotizing pancreatitis and pseudocyst. The patient, they can give, hardly can get to see a MCQ about that. But normally what comes around is basically patients having fullness after many months or many weeks of pancreatitis. You got fullness, vomiting, and what is a possible thing? So it's a typical question about pseudocyst. The cyst is there between the stomach and the pancreas, pressing on the back of the stomach, causing nausea, vomiting. And what do you do for it? You can do a cystostomy, but they won't ask. They normally ask, what is the management? It's the drainage of the pseudocyst. Again, depending on how bad the clinical picture is. And then obviously necrotizing pancreatitis is one of the very, we know the complications, one of the most complicated things in pancreatitis, and the management for that. Again, in pancreatitis, one important question, we don't give antibiotics. Any itis is actually inflammation in the body. You can say cholecystitis and, diverticulitis. Why are you giving antibiotics? Well, a cholecystitis, you never give antibiotics for inflammatory process in the body. For inflammatory process in the body, you give anti-inflammatory, which is not normally used, but it's pain relief. In cholecystitis, when there is translocation of the bacteria around in that area, then you give antibiotics. The patient is really sick. Same in pancreatitis, a patient having a fever or a high CRP in the first 24, 48 hours is not an indication of antibiotics. It would make no difference at all. But yes, if the persistent fever and showing signs of SIRS, which is systemic inflammatory response, or the sepsis, then you give antibiotics. But that again has got nothing to do with pancreatitis. It is just to stop or any chances of a collection, not prophylactically, but if there's any evolving collection there. Signs and pathology. You remember these, and I forget the name next year. So please go through these signs, and these are typical, again, 1 or 2 questions. Murphy's sign at the right of a caudal pain. You press in and the liver comes down. It touches your hand and you get a pain. Typical sign, it comes around. Boss sign, pain in the shoulder, tip of the shoulder because of the cholecystitis. Cullen's sign, hemorrhage in the umbilical area, come more of a retroperitoneal or hemorrhagic pancreatitis, even if there's any trauma pancreatitis. Gray Turner's sign, again, something at the flanks, comes under pancreatitis, hemorrhagic pancreatitis, retroperitoneal pancreatitis, because it's an organ which is behind the peritoneum. And the Rorschach sign, as you know, is more often the appendicitis on the left side. You press on the left side, and like an abdomen is because of a closed chamber. You press one side and the other side hurts, and that's what it is. There are many of the signs, guys, in the books, so please look around. I'll try to go through single best answers so that we can know exactly what comes in MRCS, what typically they ask for. Obviously, first, I should have told this in the very first place. My whole presentation is not it's not an innovation or anything at all. I've obviously taken many resources. I've used many resources, and I've taken questions from here and there. So it's all from that. So question 1. It's 18-year-old female presents to ED. Can you open the comments section? 18-year-old female presents to ED with sudden onset of tearing pelvic pain associated with a small amount of vaginal bleeding. She also complains of shoulder tip pain. She's hypotensive, tachycardic, marked cervical excitation. Now, most likely diagnosis. Now, what I would like you guys, sorry, just for a second, how many people are there? 20 or 30. I would like you, if it's possible for you guys, to write an answer in the comments section. There's a comment section. And I'll see the answer, see what exactly the maximum is thinking about and why exactly. And then we will rule out each of these options rather than just taking to the right question. So you've got 30 seconds, in fact, 15, 20 seconds. Please make a guess. There's no right or wrong. Just make a guess and we'll discuss that. Questions? Response? The comment section. Is that comment section? Right. So as very evident from the whole thing, everyone's coming atopic pregnancy, we know that. It's shoulder pain, hypertensive, tachycardic. Again, they've not mentioned about a pregnancy test, but don't worry about that. These things are not necessarily required. They might not give you a pregnancy test, but if you're giving you hypertensive, tachycardic, or reproductive age with vaginal bleeding and shoulder tip pain, it's ectopic, causing the diaphragmatic irritation, causing all this thing. Appendicitis, yes, but why would they give you vaginal bleeding? Endometriosis, no, they'll not give you this sort of picture, getting hypertension. How many times you see patients in meaty who've got endometric pain? It's a pain, it's not a septic condition. And in axial torsion, again, it's pain, it's not a septic condition. And degenerating fibroid will not come in an 18-year-old. So I think this was one of the easy ones. Question number 2. 14-year-old female presents with ED with sudden onset radioliphosa pain. Some tenderness, no guarding. Afebrile. Urine, negative. When I say negative, means no nitrites and no leukocytes. Previous menstrual cycle, 2 weeks ago. Pregnancy test, negative. Again, make a guess. Most likely diagnosed. And then we'll go through them to see what exactly you guys think and what, if not, we could have a bit of a discussion here also. Obviously, this is not an exam. You can give a right, wrong answer. It doesn't matter. I just want to have different views so that we can have a bit of an interaction here. Right. Because of the time constraints, I'll stop here. So basically, yes, you've come up with Michelmer's, you've come with appendicitis, mesenteric, fair enough. So what you're looking here for right radioliphosa pain, as I said, for those, differential diagnoses, you should come up those differential diagnoses. Female, Sudden onset right iliac fossa pain. Firstly, an appendicitis is not normally sudden. It's an inflammatory process. It's a migratory right iliac fossa pain, not necessarily, but still a process in 1 day's time. She or he would have a bowel symptoms. They would have vomiting, nausea, fever at times, but not necessarily. So it's not typically looking appendicitis. Then it says tenderness, but no guarding. If you've got inflammation in the appendix, which is sitting there in the right iliac fossa, just next to the peritoneum, and it's the peritoneum is inflamed, they should have guarding. Afebrile, I'll take it. You not necessarily need to be febrile to have appendicitis. Urine uptake is negative, so obviously that takes a few things off the picture, but you can still have a positive urine uptake in appendicitis. And then I think the clue in the question is there, which is previous menstrual cycle. Why would they give you this thing if it doesn't mean anything at all? So remember, in the MRCS exam, the most important thing is they should give you something to give a bit of a clue. Endometriosis, again, is a pelvic pain picture. Appendicitis is, as I said, I was trying to debate appendicitis. Why not appendicitis? Because it's not guarding. They're not giving a high visceral inflammatory markers, and the pain is not related to the bowel. It's more as a, as a gynecological cause. Mesenteric adenitis, it's more common in children, but yes, mesenteric adenitis, I would take. I know you can think about mesenteric because if it's not guarding, afebrile, but again, no one would mention previous menstrual cycle. This is an MRCS exam, guys and girls. This is not an FRC. They do not give you menstrual cycle without any reason. And Fitzhugh-Curtis syndrome is more of a PID, which causes adhesions in the hepatic area, causing perihepatitis. But again, the patient should be septic. The patient should have fever, which the patient does not have. So the answer goes to Michelin-Mills. In fact, should I stop here? Has anyone got any question? I'm more than happy to answer the question if I'm able to. And they want to, raise their hands or even unmute and ask a question. No worries. I can stop for another 10 seconds for these two questions. Any confusions at all? And please don't be shy. We've all been through these stages. So any questions, no question. As a weird question, you can never ask any question. Right. So question number 3. 21-year-old female presents to ED with a 48-hour worsening right iliac fossa pain, nausea, vomiting twice, tender, guarding, vaginal exam, unremarkable, urine dipstick, beta FCG, negative, white cell 13, CRP 70. Now, before we start up, what is the diagnosis? If you just hold, yeah. What do you think is going on here? Well, I think the answer is down in the options. Go to the options later. But what do you think is going on here? Just give a diagnosis. We think it's appendicitis, isn't it, guys? Why do we think that? Because it's just giving you that picture. 48-hour, worsening pain, progressively getting bad, nausea, bowel symptoms, urine beta FCG negative. You take the urine symptoms and you take the pregnancy and the gynecology, white cell 13 CRP. Now, the question is most appropriate course of action. Give an answer, guys. Another 30 seconds for you to answer this question. Right. Okay. So yeah, I love it when people come up with a different answer. That means they've actually thought about this thing. So let's talk about the ones which no one has given that answer. And I think even if they're given it, that's not a wrong answer. But laparotomy, you won't go for laparotomy for this patient. So that goes off the picture. So that's how normally you rule out the things at times. You take the most weird one out. If this is only the question. Most of you come back with abdominal ultrasound, which is quite reasonable. And few of you have come up with laparoscopic appendicectomy and an open appendicectomy, which is again absolutely reasonable. And then abdominal CT scan, absolutely reasonable. And this era, 2022, we go for CT scans for 20-year-olds. Yes, we say not to do it before the age of 40, but no, we do it. However, I would not stick to CT scan because normally in practice we are very conservative in doing CT scans for 21-year-olds. So I would take that one away. Laparotomy CT will be away. The question then would be either we're going for a surgery or we're going for an ultrasound. So with every sympathy to the people who opted for ultrasound, is that when I was picking this objective a couple of days back to get the presentation done, my gut, my practical, the answer was ultrasound. Because this patient comes to me in a daytime, in a hospital setting. and I got an opportunity of getting an ultrasound, I'll get an ultrasound. Just say there's any slightest of the doubt that this is not an ovarian, a tubular abscess, or this is not any PID or anything at all. Get an ultrasound, get the gynecological causes away, and then you have to do a diagnostic laparoscopy. Why I'm saying not open appendicectomy? In 2022, we go for laparoscopy first. So that's why open would be a bit away from the answers. Laparoscopic if. The question then would be ultrasound or laparoscopic. The problem here lies is that, again, as I said, you guys would have different competencies, different levels of your surgical experience. You might be already a PG trainee, or you might be a registrar, you might be just a house officer. Ultrasound is not a wrong answer, but for an MRCS point of view, they're asking most appropriate course of action. They're not talking the initial. So that's the difference, and that's what we could judge around this question. They're saying the appropriate course of action is actually laparoscopic appendicectomy. And you talk to consultant, all sort of, I'm not talking about that age, I'm talking about more consultants or registrars who've been training in the 1990s. They said, what's the point of having an ultrasound when you have to go into the abdomen of a patient who's septic and got abdominal pain? You have to go. So go to a diagnostic laparoscopy. You find a tubular abscess or anything at all, take care of that by the gynecologist. But in this question, the answer would be appendicectomy and the laparoscopic one. Because it's not asking the initial, it's asking appropriate course of action is appendicectomy. Question 4, 21-year-old presenting to ED with vital fossa pain. I'm just getting vital fossa pain because trust me, out of, if there are 40 questions in acute abdomen, if there would be at least 7-8 vital fossa pain. Reports blood-stained vaginal discharge, afebrile, pulse rate of 97 per minute, normal BP, diffuse lower abdominal tenderness. Most appropriate course of action. Again, guys, one of the most common presentations, I think probably 30% of patients come with this presentation. We don't know what to do. What is the expected answer from your side? Or what would you say? Amir? Right. So, because of time constraints. So, again, the question is, I don't think any one of you is going for a laparotomy or a laparoscopy because it's just too much. Patient coming with vital fossa pain has got pain, tenderness, but no guarding, and some blood-stained vaginal discharge. So it doesn't look like appendix or anything at all. You go for. So then we're stuck with two things: either CT, MRI, or ultrasound. MRI, she's not pregnant or anything at all. We go for MRI scan. So it's either CT or ultrasound. As I said earlier, 21-year-old. Will you do an investigation which is 300 times that of a chest X-ray, which is a CT scan, or do you go for a more conservative approach of going in ultrasound? And maybe the answer is an ultrasound. If the ultrasound doesn't give the answer, which normally is not the case, because ultrasound, remember, is not normally to prove appendicitis. It is to rule out the gynecological causes. So the best investigation to look into the ovaries and the uterus is always ultrasound. So in this question, we're actually trying to see what is going on in there. CT would be perfect, but as I said, you don't need that much of a radiation to answer a question. If the ultrasound says it's ovarian issue, we don't need to do a CT scan. That's the answer. You talk to the gynecological people and they say take over the patient. If it's not that, then you do a diagnostic laparoscopy. We normally try to stay away from a CT scan below the age of 35-40, unless there's some indication of any bowel symptoms, long-standing bowel history, or they're getting a history of family history of bowel disease. Then you should do a CT scan to rule out what? Inflammatory bowel disease, ileitis, or any sort of a picture which can lead to colitis or Crohn's disease. So the answer in this question is abdominal pelvic ultrasound scan. 5-year-old boy develops persistent fear following open appendicectomy for a gangrenous erythema of the wound and some abdominal distension. Next appropriate step. 20 seconds. And I'll discuss the question then. What is it? I'll wrap up. Right. Okay. So a couple of answers. Every one of you said diagnostic. I mean, no one has covered the diagnostic laparoscopy. The weird one stays away. CT scan, as I said, fibroid. You've taken it away and taken the cancer. Abdominal X-ray. You got absolutely no, use of doing an abdominal X-ray in a fibroid. What are you going to do? What exactly are they asking? They're asking you've got basically a wound infection. Quite clear. Erythema of the wound, abdominal distension. So there are two options. Either you do an ultrasound scan, the conservative management, or you open the wound. Now, this is a practical. If you practically talking about, yes, you will open the wound. Yes, you might do ultrasound scan. The reason they've asked this, given a bit of a clue here, is number one, gangrenous appendix. It is an intraperitoneal organ. You have taken it out of the abdomen. You've closed the abdomen, and then the patient has got erythema. So, are you sure if you open the wound, is this going to be a wound infection, or is this going to be a wound infection is communicating inside with the abdominal cavity? Because you open a wound and you find yourself in the abdominal area and you're like, man, I'm a bit stuck here. You're a bit of a doom, because in that case, you have to close the abdomen, or you have to take the patient back to theater for washout. So that is why conservatively they're saying this is the case. They've not mentioned the patient is septic. They've not said that. If they said that, then yes, probably theater would be an answer. But basically, ultrasound is the best investigation to see if this is a collection, a wound infection, or communication down in the pelvis, which needs drainage possibly, rather than opening the wound. And that's what you need to think about. They're saying abdominal distension. This is not a normal wound infection, guys. This might be an abdominal collection which is causing some ileus picturals. And then 43-year-old underwent lap chole with a drain left in for 5 days. The drain is accumulated 150 mils of bile every day. So it means around 750 to 800 mils. Course of action is, this is the last question. And what is your possible answer? So this is again a very typical question, is saying someone having a lap chole and the next day or 5 days later, but this one they've got 5 days later, they've got bile leaking from either a cystic duct stump, or there's a nick in the CVD, or one of the biliary channels, no anything at all is leaking, causing bile leakage. So what would you do? Again, take the weight on off and then come back to the you're a bit stuck, and then look into these two options. Again, guys, there's no wrong or right answer. Right. Okay. Fine. So the answer is, again, you all, I think probably no one is trying to go and undertake a laparotomy. I agree. Or a chest X, it doesn't make a difference. It's not a perforation. So these two are off. And they will left with ultrasound scan or a CT scan, an ERCP. Excuse me. So yes, we can debate ultrasound scan. What information, again, you need to think about you will be getting from ultrasound scan. Here, it's a clear indication. A lap chole has been done. There's a bile leak. Simple. What is an ultrasound going to do? Is it going to give any information of the biliary apparatus? Not exactly. It won't. It will show you gallstones and all those things, but that has been taken out. It might show you CBD stones, but that is not the case. What you need to see here exactly, or you need to assess or manage, is that the bile leak is stopped. At this point in time, your aim is diagnostic and therapeutic. The diagnostic is to see and at the same time do it. When you're saying diagnostically, you've already known lap chole with the drain left and bile is leaking. So guys, there's either a CVD which is leaking or there's a cystic duct, probably either one of these two cases. CT scan, yes, I will say practically in pictures, we do go for CT scans. But again, what information would you get from a CT scan? In an abdomen, which has been operated 5 days back, trust me on this one, there's a lot of adhesion in the first 5 days, and you hardly, it's more of a picture, you can't get much information from any scans. ERCP seems reasonable because you know there's a leak. You put a stent via the, we go to the ampulla vatra into the CBD. You put a stent there and you block the drainage, and then obviously you can actually go back into the abdomen. But if this patient comes on the very next day, within 48 hours, with drain having 150 or maybe 300 mils of bile, septic, what would then be the answer? So same patient, 40-year-old, underwent lap chole, the drain left in. Next day or 48 hours later, the drain has accumulated 300 to 400 mils. He's septic. He or she is septic. What would exactly be the answer? So someone has come with a laparotomy. Fine, they understand the need of going back into the abdomen. Laparotomy again. So you guys understand the sepsis is the thing which will actually make a difference here. Laparotomy again. So yes, that is not a wrong answer. But for MRCS, because this patient had a laparoscopic cholecystectomy, CT, I won't disagree. Yes, we do go for CT at that time. But if someone is septic, you don't wait for something that is completely obvious. You've got a leak in there and you need to go into the abdomen. Laparotomy is not a wrong answer, but wrong in the sense that if you've gone laparoscopic cholecystectomy, you go back and you do a laparoscopic washout. That is the difference. So in 2022, for MRCS, you would do a yes. I totally agree with what the people have said. Laparotomy, the purpose is to go in the abdomen, but you have to go a laparoscopic route, which is a laparoscopic washout of the abdomen and leave a drain, and then do an ERCP. But you have to take this clear of the sepsis first. Right. Okay. So that is for the acute abdomen. Just one thing before I go back to one of these sites, because as I said, this is one of the things you have to look around, and that is so that's the one. So you have to make it sure that you are proficient in looking into these diagnoses. In lower abdomen, diverticulitis comes with inflammation, in high inflammatory markers, abdominal pain, diarrhea. Ulcerative colitis, typical picture, but they'll give you some long-standing history of family history of patient long-standing diarrhea. Diverticulitis normally does not have any long-standing history. It's an acute episode normally. Ovarian cyst, it would come with a sudden onset of pain. Ectopic pregnancy, they should give you either a hypertensive tachycardic patient or a pregnancy test which is positive. UTI, they'll give urine district positive, or they will give you a pain which is going from loin to groin, unless they give you a colicky pain in the loin to groin, and that's a renal colic. Pyelonephritis, it is septic picture, same as a UTI, but worse than that. Because of time constraints, sorry guys, I'm going a bit fast. Appendicitis, typical migraine italic fossa pain. They might give alvaroscope, but not normally seen in MRCS. Crohn's disease, again, long-standing history of irregular bowel habits or diarrhea or mucus discharge. And on right-sided pain, that you think more of Crohn's or ileitis, anything like ileocecal disease, rather than appendicitis. And then don't forget, there can be cecal diverticulitis. It's just not on in the left side, on the right side. The rest, I think I've already tried as much as possible. Again, this session was not meant to teach you surgery or teach you anatomy. It's more about to teach you what comes in the practical acute abdominal situations and how to deal with it and how to approach the question. So many resources I know, but I mean, I've done MRCS with 7-8 years, but I know the resources have more or less changed a bit. EMRCS remains the same. Past SCS, I did pass it, but EMRCS a little bit. I think definitely EMRCS is a better one. Teach me surgery, teach me anatomy are good sort of resources. You can actually look around and learn anatomy, and then obviously you have to learn about a few things in the abdomen, which is it's not the liver segment which is important, but what is important is the biliary apparatus. You need to know the celiac artery. Its branches, 3 main branches of celiac artery, or you need to know in the diaphragm what are the levels of the IVC, T8, or aortal opening or the vena cava opening. These are the levels typically. Or if I would say what is the level of the L1, the pancreatic or SMA. These sort of things very briefly anatomy, but not very deeply. They don't ask much about it. Obviously, the Royal College of Surgeons website, have a look into that in the syllabus also. 2 things which I normally recommend myself because I've seen them. I'm still, well, I've forgotten a bit of it, but anyhow, Ackland's Anatomy and Harold Ellis Anatomy. Ackland's Anatomy you can get on YouTube. It's a beautiful dissection of the body and abdomen, limbs and all those things. Please do have a look, even if you're doing MRCS or not doing MRCS. And it's going to be very helpful in anatomy, and not only anatomy, it's more of a surgical anatomy inclination towards that. So I'll close off call it a day from my side. Thank you again to KEMCA. Thank you, Talha, for the initiative and starting. This is just a sort of an effort to give you a bit of an idea of the acute abdomen. I'm more than happy for you to contact me via the KEMCA for any questions or anything at all, or anything for guidance. More than happy for that. All the best, and I hope you all will be doing very great. Thank you. Over to you, Talha.
So first of all, thank you very much, sir, for your time today. So guys, we will be live at 6 p.m. UK and 10 p.m. Pakistani time every Thursday, and we'll have a specialist registrar or a consultant from that particular field. Dr. Amir is an ST5 going into ST6. It is just to let you guys know that for people who ask that if you can get surgery here, yes, you can. Yeah, you have to work hard for it, but you can get it. You will find out in the coming weeks that you will get a lot of speakers from Pakistani, Indian, or other IMG graduates who have been working here as trainees. So if any one of them can get it, it means anyone can get it from our side. So hopefully we'll see you next week, and thank you all for joining. Thank you so much.